this screen. Okay. Do you guys just see, tell me what you see. Do you see the slides?
I see the slides.
Perfect. Okay, it works. Okay, how about uh play from current slide? How about now? Do you see just the slide and no speaker notes?
Yeah, just a slide. I don't see anything.
Excellent. Okay, perfect. It works. All right. I've been wanting a double monitor for a very long time, so I'm glad it works. So, all right, we'll get started. So we're just covering anxiety disorders again today, so picking up where we left off. I don't think we'll get to obsessive compulsive disorders, but we will see. Um, yeah, and then stop me if you have any questions. I actually can see a few of you, kind of like your tiles, so I might be able to monitor the chat if you are typing in there, but feel free to unmute. And then I said it last Monday, but just a reminder, if you're choosing to do assignment 3, it's due this Sunday. And the assignment is related to obsessive compulsive disorders. So you might want to wait, but it's up to you. Okay, so let's skip all of this. We talked about this. I think we talked about parenting influences. Yeah. So we ended here on anxiety maintenance. And we talked about how in the context of especially younger kids or just family-based context, when we're thinking about youth with anxiety disorders, how family accommodation can play a large role, and a lot of times inadvertently. And so from a behavioral perspective, when we're thinking about intervention, a lot of times that's one of the things we provide psychoeducation on. It's explaining that, like, so in this example with David, where we talked about he's afraid to get on the bus, he makes a big fuss about it, not necessarily to get out of it. It's probably just like he's very dysregulated. But the function then of his mom coming to the rescue and just saying, okay, never mind, I'll just take you to school. You don't have to get on the bus. That gives him short-term relief, which is okay in the short term. And then in terms of the long term, only reinforces that anxiety and the belief, if there's any underlying beliefs about I can't do this, or it's going to be the end of the world, or like that feeling is so bad, I can't tolerate it if I'm put in that situation. So the long-term impact ends up being really important because that's that negative reinforcement cycle. We're only increasing the probability that we're going to have this avoidance and anxiety about these particular situations when we keep getting rescued, so to speak, or when we avoid it ourselves. So it's an important thing that we consider in anxiety, but also in OCD. And we'll talk about OCD later on just because it's part of the section, but I think I'll say later on that some of the underlying like etiology factors, there is some belief about some shared etiology, which when we go back to that internalizing slide we looked at, that makes sense. It's kind of like within the internalizing spectrum where we have these obsessive compulsive thoughts, we have anxiety. So previously in the DSM, there was a shared section with OCD and anxiety all being in one chapter, and now they're separated because there's more evidence that they're similar, but they operate a little bit differently. Some of the regions in the brain and the etiological networks are a little bit different. So we'll get to that in a bit, but family accommodation plays a role in both. Okay, so this is just a reminder going back to why do we care about reinforcement? What are some of the behavioral principles that we need to keep in mind? Because this is what's going to inform therapy. And the evidence-based intervention, which we'll talk about on the next slide, for anxiety is going to be exposure. So with that, we need to know what the behavioral principles are. So with extinction, remember that this is the process by which a conditioned stimulus no longer provokes a conditioned response. So in this picture, we have on the left, the unconditioned stimulus. So let's say that's a shock, and the unconditioned response. So you scream or whatever, you feel the shock, you get whatever that feeling of being shocked is, unpleasant. And then we pair that unconditioned stimulus with the conditioned stimulus. And so because it gets paired with the thing that has an unconditioned response, we then learn over time that the conditioned stimulus results in a conditioned response. If we do this repeatedly, what happens then? It no longer provokes the response. So those are the behavioral principles. Very briefly, if you don't remember it, I would go back to I don't remember what chapter it is, maybe like chapter 4, chapter 3, where it talks about behaviorism and it talks about classical conditioning, operant conditioning. I would go back there if you feel a little bit lost. But this is the principle and the premise of exposure then, which is, oops, yeah, extinction. So the evidence-based intervention for anxiety disorders is going to be a behavioral approach or cognitive behavioral with a big emphasis on the B, behavioral. So I had a supervisor who, when I was working primarily with anxiety disorder, or sorry, ADHD, but I saw some anxiety disorders. His orientation was CBT, which is very common. Um, a lot of people in doctoral level degrees tend to have that CBT orientation by virtue of the program and the evidence base. But he always said that he was CBT with big B, meaning really behavioral focus. And so think of that when we're seeing CBT here for anxiety disorders. It's cognitive behavioral with a pretty strong emphasis on the behavioral side. So the behavioral principle being we're using these extinction principles, the conditioned stimulus, all that stuff to help us uncondition, basically like get the response of anxiety to kind of basically weaning ourselves off, if that makes sense. So extinguishing that anxiety response. So it's exposure that's going to help with that treatment. In general, so exposure therapies use those extinction principles, which we just talked about. In children and adolescents, parents are often recruited to participate in the exposure, and in large part because of this family accommodation idea. If the parent is playing a role in reinforcing this behavior, the anxiety that comes along with whatever situation they're in, then we want to engage the parents, not only in psychoed, but also in participating in the exposure. And a lot of times we looked at our slides a few slides back with how we think environment plays a role in anxiety. And one of those would be like parenting. And so, or like parents' own psychopathology. So let's say you have an anxious parent who models anxiety, again, like not intentionally, but their behaviors signal anxiety. They signal that there's some sort of threat. That exposure, we already know is hard for the kid. That's their treatment. But a lot of times doing it alongside the parent also helps them kind of get through their anxiety when it comes to the child and the exposure that we're going to do with the child. So it's helpful to have parents for many different reasons. Those are a couple. Uh, Cognitive behavioral therapy. So again, CBT. So we're going to consider the thoughts, our emotions / physiological symptoms, and then the behavior with a pretty large emphasis on the behavioral side. So it's going to combine the exposure from the behavioral side, and it's going to combine cognitive restructuring to get to kind of manage the thoughts that we're having. And again, something that's kind of additive with behavioral therapy when it comes to anxiety versus, and actually probably a little bit more than I would say like depression, is this emphasis on physiological activity, like physiological symptoms. So as we're talking about emotion, how you're feeling, which someone will say is anxiety, we're also going to kind of tap into what's the physical symptom that you're feeling. Is it your chest is tightening? Is it your heart is beating really fast? You're feeling flush. So those are the things that we want to be able to recognize. So signs of anxious arousal, we want to be able to say, oh, okay, when I feel that, I'm able to link that to anxiety. Being able to identify thoughts maybe that get in the way. So sort of this like catastrophizing is very common. I used that term last week with depression, but just this idea that like the worst thing possible is going to happen. So just identifying if there are any distortions and kind of challenging that and seeing is there evidence for it, or if there is evidence, is it proportionate with the amount of anxiety I feel? And if it's not, then we tone it down a little. And then we're going to employ different strategies for managing the anxiety. The graph on the right just shows like the process of exposure in general therapy. So your subjective units of distress are on the y-axis. So that's that 20, 40, 60, 80. So the higher up we go, the more distressing it is. And on the left-hand side is time. So over time, well, so initially maybe our subjective units of distress is at a 20, perhaps because we are avoiding things. And then our subjective units of distress go up a little bit as we're doing exposure work because it's obviously uncomfortable. And then over time, it eventually kind of falls down over time with the extinction principles. And I think we also learn that it's not as scary as we thought. And this can take a while. A lot of evidence-based interventions are designed to be short term. And in practice, it's not always going to be an 8-week intervention. You might be seeing someone for a year, or hopefully less than that, or maybe longer than that. So these are the principles that's going to underlie anxiety treatment when it comes to evidence base. So it's just important to know what the principles are rather than the length. And then keep this one in your mind. So the CBT example that I have here is Coping Cat. So that's an evidence-based intervention for young children with anxiety. And in a few slides, I think I'll show you some like components of the manual. So just adding more here. Again, we're all just kind of I'm a broken record. You're using extinction principles to extinguish your anxiety response. So we're not just throwing you in and saying, okay, here's that anxious situation, like go do it. It's not bad. That's not what's happening. It's a very systematic way of exposing the person to the stressful situation. And the idea is to gradually reduce our fear over time. So we gradually work our way up into the most distressing thing. And by that point, you feel a little bit more equipped because you've done these increments of anxiety provoking situations that have gotten a little bit harder up until that point. So that's one way of doing it. We would call that a graded exposure. So on the right-hand side, doing things starting from the bottom where it's fear rating of 10, like in terms of bottom of your distress, and working your way up in a therapeutic setting. The other one can be flooding, which is not the same, not all at once. And so there's different ways of systematically exposing. I think most people do this graded exposure. And especially working with kids, I always do graded exposure. And it's a collaborative process where we say, we are creating a fear hierarchy. You might call it like a fear step ladder, a fear ladder. And you are working with them to like collaboratively decide like what's the next thing? What's the next thing? The important thing too when you're developing a fear hierarchy is that you're actually getting at the underlying fear. So clearly in this chart, like it has to do with spiders. And this is, I mean, this could be a phobia, but it doesn't matter. Whatever we're going to set, whatever it is, the anxiety principle remains. And so this is the exposure that's being used. But in this case, it's clearly the spider that is the anxiety provoking stimulus. So you'll notice that all of these are related to spiders. If we are doing, I'm thinking about, okay, I worked with a kid. Well, he was a teen. He was 12 when I saw him, then he turned 13. He had social anxiety, and there were a lot of different circumstances where we could practice the exposures. It didn't have to always be in one setting. So we got really creative, but I had to make sure if we're adding stuff to the hierarchy, is it still getting at this underlying fear of whatever it was for him for social anxiety. So some people have a fear of like, I guess like perfection, like not looking competent. So that's one thing. Other people might have a fear of like, it's not even about competence, it's that I might mess up and I'm just going to be so embarrassed and that would be the end of the world. Or, I'm going to say something wrong. Could be both. And so, whatever it was, something that we had to integrate into his hierarchy. So, we had like a couple things, like the lower level things were like him. Gosh, I can't remember. We could do imaginal, we could do in vivo, like in our sessions. He had some things to do for homework, but we got really creative. Some of the time he did like impromptu, like, I don't know, like a minute speech in front of me, which he hated. But the idea is that we can get through this. And that was a little bit higher on his hierarchy. So we had garnered enough like support, like felt like he had enough confidence to be able to do it by that point. There were other things like for homework, I had him, I think it was like, oh, ordering at the drive-through. Like he couldn't drive. His parents drove, obviously, but they would pull up a little bit and he'd have to roll down the window and order at a drive-through. And that was really hard. That was probably like a 4 for him out of 10. And so eventually we worked up into him going into the like fast food place and ordering. And mom was there and gave him money, but he had to speak for himself. So that was an example of like you kind of have the comfort of being in the car from the drive-through perspective that you don't actually get social feedback the way you would in person. And so that was something that we stretched out over time using the car and then getting in person. And so it was silly when he did it, but it made sense. And that's part of why I say it's important to collaboratively generate it because we want buy-in from them. And the other thing I'll say too is you want to explain before you create the ladder, you want to give the rationale for, actually a lot of times we avoid a lot of these things because they're so distressing. And so we don't actually give ourselves opportunity to learn how to manage them, or we don't give ourselves a chance to kind of see what we're made of. So I think talking about it is important first rather than just saying, okay, hi, we met in session 1, session 2, we're doing this. So you do need to have some ramp up and explaining, like you can use different analogies. You might say like, I don't know, if you're scared of swimming, you think you're going to drown. Well, we're never gonna, well, okay, that may not be the best example, but something like we dip our toe in the water first. We're not gonna be able to swim unless we literally practice submerging ourselves in water first. So we might just say, like, you need to dip your toe in first and then sit in the water first, and then we can start learning how to swim. So just using analogies that might stick with them are important. Another important aspect beyond just the actual exposure and doing the fear ladder is practicing relaxation training, and that really taps on into the physical symptoms that we were talking about. So first we want to ensure that there's awareness of what's going on for you. So if it's, yeah, when I have anxiety, I immediately notice like I start sweating, my heart starts racing, and that's what's happening for me as I'm doing this exposure. So we want to pair it with a bunch of strategies for relaxation. Some of those things can be, I mean, just like deep breathing. And again, this is like with little kids. So if you're teaching them like deep belly breathing, you might say, smell the flower, like, breathe in really strongly, and then exhale. So blow out your candles. So using just different analogies. Progressive muscle relaxation too, which is tightening like different regions of your body. So you're tensing certain muscle groups. And as you're tensing and relaxing, you're saying, notice the feeling of tension to relaxation, and that can be helpful. So those are the like physiological things and the behavioral side. And then as far as the cognitive side, when it comes to CBT, thinking about what are those anxiety cognitions? Is there any self-talk that's happening that's sort of maintaining the anxiety? Or yeah, are there any underlying thoughts? These are just some examples that the book gives that are common in kids. So, like, that dog looks dangerous. If I'm away from my parents, something bad may happen to them. People will think what I say is stupid. I know that I will embarrass myself in front of other kids. I usually get very good grades, but I'm going to fail this test. I know that other kids are talking about me. I know the new teacher is looking through the class list and will call on me. This is going to go badly, and there's nothing I can do to make the situation better. So, we talked about this already, but some of the stuff is catastrophizing or like fortune telling. So, anywhere that says like I know what's fortune telling, like we don't actually know. We can't tell the future. Um, I usually get very good grades, but I'm going to fail this test. That's like assuming the worst. So, catastrophizing, the example I've given before of like, if I fail this one test, like I'm never going to graduate college or things like that would be like black and white thinking. So these are things that are helpful. Like this other one, if I'm away from my parents, something bad may happen to them. That's something that isn't necessarily black or white thinking, but that's something we might want to kind of explore further. If this is an anxiety cognition, is there any like, or is this more of like an obsessive thought that kind of veers more into OCD? So depending on whatever your top thoughts are, that may be unhelpful. So these are like some of the terms that I've already used. Then we will work with cognitive restructuring. So for the example, I don't have any friends, we might shift that eventually to something else. I forgot to call my mom on her birthday, so I'm a failure of a daughter. We might want to shift that to something else. We've used this example too, before already. We saw it in the depression chapter. Um, you can do this by using a thought record. So CBT is very well known for all of this work with challenging thoughts, providing evidence. And so there's a systematic way of like recording those things. You might just have them do for homework one week. Okay, write down all the situations that came up for you. What were you thinking? How did you feel? What did you do in the situation? And as far as the thought, like number one, is there evidence for it? And a lot of times we might say, like, actually, if I reflect on it, like, no, not evidence in the way that I thought. So, like, if we say something like, with this situation here, I was running to catch the subway and tripped and fell down the stairs. Okay, if that's a pretty crappy situation, what are we thinking? Everyone's looking at me and they think I'm an idiot. Okay, so it's not terrible, but yeah, that doesn't feel good. Your emotions are probably, I'm so embarrassed. I feel so sick or whatever the emotion is, the behavior is, I don't know, like I'm avoiding going. I eventually ended up not getting on the subway because I was so embarrassed that the people that saw me were also going to be on the subway with me. Alternative thought would be something different. So like, is there a possibility that something else could explain what just happened, or a possibility that what you just said may not ring true? Something that I can think of is that instead of saying everyone is looking at me, I mean a balance. So a dialectic might be some people saw me, most people probably didn't. Or yeah, some people saw me, but I don't know what they're thinking inside. I actually don't know if they think I'm an idiot. So that could be an alternative thought. And then as far as evidence, asking yourself, well, did it actually happen? Like they think I'm an idiot. Something you might ask is, well, how do you know that? And then they'll say, well, they looked at me. Okay, so if they looked at you, are there any other possibilities other than they think you're an idiot? And then they might say, well, probably not, but I guess, well, yeah, maybe they looked at me. Sometimes I just randomly make eye contact with people, or yeah, maybe they did look at me, but then they looked away. So actually, I don't know that they kept thinking about it. So you just are kind of garnering more evidence, giving opportunities to restructure thoughts. And over time, the idea is that that gets easier, and it can be a lot less painful when you feel like all eyes are on you. Okay, so Coping Cat is a CBT program, and this one is specifically for kids between 7 and 13. These are different components of the intervention. So psychoed, so like what is anxiety? What happens for us when we have anxiety? What's this reinforcement cycle? Relaxation training is what we talked about. So just teaching different somatic management skills. So if we don't have awareness of what's happening in us, that's the first thing. So just we need to build awareness because we want to be able to say like these are maybe some warning signs, like I'm starting to feel hot, like I feel it creeping up on my neck. Okay, that's a good time to start using a relaxation skill. So that's from that perspective. Cognitive restructuring is exactly what we just talked about. So replacing maladaptive self-talk with something that could be a little bit more constructive, or just at least a more of a balance. It doesn't have to be all flipped the other way, but over time, when we have more balance, we fall in the middle, that helps. Problem solving. So there are going to be times where you have to be in these challenging situations. Of course, like we can't avoid everything forever. And so problem solving is one way to help the child kind of in advance navigate, okay, what am I going to do in this situation? And helping them develop the confidence to do that. So we might kind of for homework look in advance. So okay, you have a presentation coming up. we can't really get out of that. It's going to be in person. You have to stand in front of your class. There's like 20 people there. Okay, so let's talk about it. Like let's problem solve. So we might kind of do something in advance to help the child develop a plan and feel confident. Reinforcement is going to be really helpful too. So especially with little kids, or any kid, but this is just remember there's been so much history environmentally in terms of the avoidance and anxiety being reinforced. And so we really want to provide reinforcement for them doing the things that still evoke anxiety, but prove that, show that there's effort being done. So we don't have to necessarily reinforce like completion. I mean, ideally, yes, like if they're doing an exposure, we want to reinforce the effort though. So even if they tap out or something, like we're still reinforcing that they did something really hard and we want to see more of it. So a lot of it is relational, just like using yourself as the therapist as a reinforcer. Um, but especially if you're having a child do exposures at home for homework, they should be like not they shouldn't be the first time someone's doing it. So it might be something like a level of the fear ladder that we've already been working on, and then I'm going to assign it again for homework. And I've taught the parent how to do it. Maybe they watched us do it in the session. So in that case, if they're doing something for homework, I might ask the parent, like, can you guys develop a system? Like, is there anything you can do to help reinforce this behavior at home? Whether it's like just again relational, like encouragement, or even if it is like it could be a small token, like, oh, you get to, I don't know, have ice cream, or could say, giving choices, like you get to choose dinner tonight, or you get to choose the dessert tonight, things like that. And then modeling. So we take as the therapist, we're also taking on the role of the coping model. So we're showing how to do things. So again, with like relaxation training that we talked about a second ago, do it with them. I can do it with you. I sometimes get nervous too. So using effective coping and modeling that for the child. And then exposure is the part we just talked about. So that's like the actual exposure to the anxiety provoking stimuli. And again, this is the order that they do it in for Coping Cat in particular. And they have a bunch of different like acronyms. Oh, and there's weekly homework. You don't have to watch the video. It's a video on Coping Cat, but oh, it's stuck. Oh no. Okay, never mind. So again, Coping Cat has a lot of different acronyms, and so the fear acronym in particular is like how to help help them remember like kind of the steps that we're doing in the intervention. So fear stands for feeling frightened. So that's the first part, like somatic awareness. Do we know when we're feeling nervous? If we don't, that's what we're going to practice. Sorry, there's like a fly. Um, expecting bad things to happen. So can we start noticing that we have some negative thoughts happening? That's the cognitive stuff that we're going to help restructure. The A stands for actions and attitudes that can help. So that's where we're problem solving. We're um, modeling things in the session for them, and then results and rewards is like the reinforcement side. So that's the order that we would help them remember it in the Coping Cat module. But yeah, just one example of an evidence-based intervention for anxiety disorders. Okay. Questions about that before we talk about diagnostic criteria for some of the disorders? No? Okay. So here are a list of anxiety disorders within the anxiety disorders section of the DSM. Um, I think we'll talk about most of these, or we'll at least touch on all of them, I think. Something to note too is that OCD and PTSD/acute stress disorder are no longer part of the anxiety disorder section. That's what I alluded to earlier. And so they all have their own separate sections. And within those sections, there are related disorders. So this is just anxiety. Okay, so separation anxiety. This is, and actually the order, I'll just scroll back. The order is also generally in order of like, I think it's like etiology, like when it happens. So we tend to see separation anxiety much younger in early kids. So like in terms of lifespan. So we see this earlier on than some of the other stuff. I think that's the order it's in for the DSM. Sometimes it's in a particular order and sometimes it's not. Okay, going back. So separation anxiety, criterion A, developmentally inappropriate and excessive fear or anxiety concerning separation from those to whom the individual is attached to. And there need to be at least three, between 1 to 8, three symptoms that the child or the parent endorses or that can be observed. So potentially recurrent excessive distress when anticipating being separated from the figure, persistent or excessive worry about losing that figure or that there's going to be possible harm. So that actually came up in the self-talk chart we looked at. I think it was if I'm away from my parents or something, like they're going to get in an accident. That's an example that like kind of underlies separation anxiety. Persistent excessive worry about experiencing an untoward event. So in terms of the attachment figure, so things like I'm going to get lost from my parents, um, I'll be kidnapped. And again, remember it's like an excessive amount and it's disproportionate and it's causing impairment in order to get a disorder. It's not the same as, a parent teaching a young child, like, you got to stick with me, we can get lost, you can get kidnapped, like, that's different. This is like excessive fear. In most situations, we're seeing this, and it's causing a lot of distress. Persistent reluctance or refusal to go out, away from home, or anywhere because of the fear of separation. So, no, I don't want to go to school, like I'll be separated from my parent, or no, I don't want to stay home, like my parent is going to the store, I have to go with them. Excessive or persistent fear or reluctance of being alone at home without major figures. That's the example of going to the store without them. Refusal to sleep away or go to sleep without being near a major attachment figure. This like often comes up when kids get a little bit older and there's reason for the child to be separated, like I don't know, like going to camp or needing to stay with grandparents or staying with another figure for like a day because parents have to go away for something. So, or like in terms of the sleeping arrangement, there's something like pretty dysfunctional about or distressing about being away from the parent. Repeated nightmares involving the theme of separation, and then, as always, a lot of somatic complaints. So the reason we looked at the internalizing slide earlier in the PowerPoint is because of the overlap between all of these different types of internalizing symptoms. And one of the most common ones for kids for anxiety and depression are those somatic complaints. So saying my tummy hurts, I can't go to school, things like that. Sometimes it really is that, but when we're talking about an anxiety disorder, a lot of times if I hear things like always having a stomach ache, like they don't feel well before school, um, stomach hurts all day during school, and assuming there's no other like health condition, like no GI issues, that kind of raises flags for me that that might be some anxiety, and then I would assess it further. In terms of a time qualifier, so this sort of anxiety, fear, or avoidance needs to be pretty persistent, so pretty ongoing, and at least 4 weeks for as long as 6 months, for or more in adults. As always, C and D kind of matches what we think about when we talk about can't be explained by another disorder and should be impairing. Okay. Um, Something that I think is helpful to think about too is, again, in the context of kids, school refusals. That's why I gave the example of a lot of times when I hear my tummy hurts before school, I feel sick at school, I don't want to be at school. Sometimes something to look at potentially is separation anxiety. It could be another anxiety disorder or it could be nothing, but usually I will go to anxiety and try to assess, like, is it generalized? Is it so? A lot of times I see people with social where it's like I have a class next period or I'm presenting or I like just hate school. I'm really anxious around people, and that tends to be more social anxiety, but also for younger kids I've definitely seen separation. So yeah, often associated with separation anxiety, but there are other causes, of course. And then again, when I say like assess further, it's like determining the function of the anxiety or whatever the behavior is associated with the anxiety. So some sort of functional analysis could be helpful. And then the majority of clinicians emphasize the importance of getting the child back to school. So in general, if we're seeing distress, and this is not just specific to anxiety disorder, but the goal is to get people back to functioning, back to normative functioning, back to into their environment. That way, they're not like taking too much time away, or they're not causing more problems for themselves down the line. So especially with school, missing a bunch of school is like has pretty long-term impacts if it's like pretty severe. So like I've given the example of a teen that I'm working with. She doesn't have separation anxiety disorder. She's the client that I mentioned who has like that unspecified eating disorder, but a lot of social anxiety. And those two things together have resulted, she doesn't do this anymore. But when I first started working with her, the previous year, she had probably, I don't know, been to school a total of like 2 weeks in the entire semester. And it was really, really impairing for her because now she had to redo a whole other, like was held back basically, had concerns about going to an alternative school. And so just school refusal and avoidance at this age is like really, really can be detrimental in terms of like how long it's going to take to get back to functioning. So that's why in the context of therapy, if we can get you going back to school, that's our goal. On top of obviously alleviating the anxiety symptoms. Okay, so that's separation. Specific phobias are different. So this is having like pretty intense acute fear or anxiety about a specific object or situation. So things like flying, being afraid of heights, maybe animals, or like seeing blood drawn or getting like an injection. So like maybe a vaccination, things like that. Um, the object, so this stimulus that you're afraid of or like have really excessive anxiety or fear about needs to nearly always provoke this immediate fear or anxiety. It's not some of the time or only when it's in this situation at this doctor's office or only when I'm at an amusement park. It needs to be across the board, pretty consistent that that stimulus is going to provoke that response. And because of that, we also need to see that the person is avoiding it actively or they endure it with fear, intense fear or anxiety. So again, that's like that impairment. Um, it's always going to be out of proportion. So like the level of intensity is perhaps disproportionate to the actual danger of the threat that it poses. So there might be, I don't know, like if there's an animal, yeah, perhaps there's danger associated with like a dog, for example, but the level of intensity that they're experiencing in terms of anxiety or fear may be disproportionate to the actual threat that this thing of animal poses in the situation. Needs to be persistent, lasting at least 6 months, and as always, needs to be causing distress. There are specifiers that you can put in the DSM. So you can say specific phobia with like animal specifier, natural environment, blood injection injury, situational, or other. So something to point out here too is that phobias are different from things that are developmentally appropriate in terms of a child's fears. So again, always in the context of normative development, what's abnormal versus normal. So in general, it's pretty normal to be like, I guess, like somewhat afraid of heights, like somewhat afraid of animals, perhaps, especially depending on your household, if you've been raised with animals, socialized with animals. A lot of that is normative. And this is going to be really different. This is like, again, it's excessive. It cannot be reasoned away. There's no way around it. And it's kind of almost involuntary for us to have this experience. And ultimately, it then leads to avoidance. So, in children, common phobias are heights, animals, insects, blood injection. And a lot of times, as we get older, that kind of goes away. But if we still continue experiencing it and it meets all these qualifiers, these criteria, then we might consider a specific phobia diagnosis. Okay, I have not. You'll have to tell me if you can hear the sound. I'm going to play it, and if you can't hear it, unmute and tell me.
Good job being calm while he puts his paw on you.
Just a few months ago, this would not have been possible.
When I saw a dog, I thought She's like gonna jump on me.
Zoe's mom said it got so bad her daughter would cross the street to avoid coming into contact with a dog.
Nothing is worse for a mother than to see your daughter, or any child, feel that afraid.
Experts say certain stressors can cause fear, anxiety, or obsessive compulsive behaviors in a child or teen.
The child starts to avoid things that are provoking that sense of distress.
Psychologist Jill Aaron Rich May says parents tend to help kids avoid those triggers, creating a habit.
Let's cross the street. Let's move away from it. Let's not get yourself upset about this.
So she's leading a study investigating whether exposure therapy can help children with emotional disorders.
Moving toward and experiencing uncomfortable emotions instead of avoiding or moving away from them.
Zoe met with a therapist to talk about her fear. Then she was gradually introduced to pictures and videos of dogs before meeting the real thing.
At first, Zoe would watch a dog from another room, and then slowly she became into the room.
After 8 sessions, this was the result. Zoe was able to play with Bowser without any fear or anxiety.
He was sitting on my lap. I fed him treats. I was playing with him.
Sometimes he gets very overexcited.
The doctor says that parents can actually practice this exposure therapy at home, but advises you to be very positive and patient with your child. The study, funded by the National Institutes of Health, is also training more therapists about this form of cognitive behavioral therapy. For HealthLink, I'm Amatia Dreesy.
Okay. That psychologist also that was just talking, Dr. Jill Enrich something May. She actually also developed the Unified Protocol for Emotional Disorders. I think I might have included it somewhere in these slides, but that's also a unique kind of transdiagnostic intervention that kind of cuts across, again, like the internalizing spectrum. So any kind of emotional disorder in terms of anxiety, depression, like her protocol kind of gets at like the root of it, which would be emotion regulation. So she does a lot of anxiety work, but also testing out that unified protocol that she has been developing for kids. So I think that was helpful to see her commentary on exposure for phobias. Okay.
Good job being calm while he puts.
Wait, just kidding. So etiology of specific phobias, again, a lot of this is going to sound pretty similar because of the behavioral principles that we see that are relevant. So there's a couple different theories. So there's our two-factor theory, which was proposed in 1939, and it explains the development of phobias through both classical and operant conditioning. So it says both things are at play. The other one is prepared classical conditioning, which is also by Seligman. And this is instead saying we're more likely to fear objects which we are evolutionarily primed to fear. So things like snakes, spiders, heights, things like that. Things that there's an evolutionary, like theoretical backing to believe that why we would be afraid of that. This image on the right is the two-factor theory. So it's the one that considers classical and operant conditioning. So in step 1 is the fear acquisition. So we acquire the fear, we develop the fear response or the anxiety to whatever the stimulus is, and that's through conditioning, classical conditioning. And then operant conditioning is what helps with the maintenance of it. So when we talked about that like negative reinforcement cycle, that's just in general one way to think about day to day, like how things are maintained. But from a theoretical perspective, this two-factor theory, I think is helpful for thinking about how acquisition and maintenance can be a little bit different in terms of the starting point, like how it happens, like the mechanism. Okay. Moving on to social anxiety disorder. So that's like the actual name in the DSM. And in parentheses, it's also called social phobia. So it follows the specific phobia because this is a social phobia, but it has its own name, which is social anxiety disorder. So with this is any fear or anxiety about one or more social situations where the individual has to be exposed to possible scrutiny by others. So it can be in the context of social interactions, like having conversations or performing in front of others. And specifically with children, anxiety needs to occur in peer settings and not just with adults. The reason for that is because, again, we're looking at what's normative for a kid. It's actually pretty normal for young kids, like let's say a 6-year-old, to be nervous with adults. And the adult is, if they're adults, they're grown-ups, they're different from their parents. There's a level of respect. So it can't just be in the context of interacting socially with an adult. It also occurs with peers. The fear ladder that I had talked about earlier, where I said I developed something with a client that I was working with, he had social anxiety disorder. And so for him, it was both of these occurred for him where he had social interactions that he was really nervous about. So, like having a conversation, like ordering in front of, like, just, yeah, ordering food was like really stressful. Um, Being observed, he wasn't really super stressed about that, but then performing in front of others, so giving a speech, which is why we did those impromptu speeches. Those are examples of what we're talking about when we say social anxiety disorder. The specific fears, the individual fears that he or she will act in a way or show anxiety symptoms that will be negatively evaluated. So again, this is getting at like the cognitions, the self-talk. So belief that it's going to be embarrassing, or I'm going to embarrass myself, I'm going to be rejected by other people, or I'm going to offend someone by doing this wrong. So there's some sort of cognition about negative evaluation. And then like specific phobias, this needs to nearly always provoke fear anxiety. So again, it's not just, oh, only in this one context. It sometimes is moderately anxiety provoking. This is like pretty marked fear nearly all the time. And then there's a little qualifier for kids. In terms of, so with a teen, you may not see crying necessarily. I mean, you could, but I think in children, we're more often seeing when it comes to how they express their anxiety or fear, it's that tantruming, crying, or freezing and clinging to their parent, or not speaking. So those are things that, again, could be explained by some other disorder or not at all if it is not like doesn't raise to the level of a disorder, but something to consider in social anxiety. Social situations are avoided and or endured with pretty intense fear or anxiety. Like it's pretty bad. Like they'll avoid it. And if they have to do it, like it is like near the end of the world for them. It feels so intense. Again, out of proportion to the actual threat that's posed by whatever the stimulus is, causes significant distress or impairment, can't be explained by all these other things. And then you're allowed to say if there's a performance only specifier. So is it only in the context of public speaking or things like that? Yeah, I think that's all I want you to get from that. Oh, the other thing that you might see in terms of like manifestation. So we talked about school refusal earlier on for separation anxiety. That's also something to consider here. They might miss events or like, yeah, any extracurriculars might be really hard to do, or they might miss it. They might try to go home. This is the example I gave where like going to the nurse's office to avoid doing things like that. That might be potentially a signal that it might be definitely anxiety, maybe social anxiety. Okay, and then here is an example. Oh, this is the fear ladder that we did together. It's kind of hard to see, but on the top, I wanted us to remember, again, I'm thinking about that same client that I mentioned earlier, that 12, 13-year-old guy I worked with. We wanted to make sure what's the core fear, like can we name what the anxiety is about? And he had social anxiety and he gets nervous in different social situations where he might be judged or criticized by others. So some examples of that we kind of determined were unfamiliar people. So like that's why the drive-through was so interesting, because he probably was going to get different workers at the drive-through every single time. I also had him go to like a store like H-E-B or Walmart or Target and like have to ask a question of a worker there because that was really stressful, that they were unfamiliar people and he felt Like if we hadn't done these exposures, he probably would never ask for help ever. And sometimes he needs help. So I think that was functionally impairing for him. Other things, public speaking and feeling really nervous that he'll make a mistake in front of people. So we did our ladder from bottom to top. So the things on the bottom were he rated this 2 out of 10, 3, 4, 5, 6, all the way up to 10. And we would repeat a step until basically his fear, his subjective units of distress, so his SUDS, was generally half of what it was when he first started it. So if let's say we were going to do, I don't know, number 6, order food at a drive-through only at the speaker box. And that was a 5 out of 10. I would have him for every exposure. Okay, let's track all of this. So he would say, okay, I did number 6 on the right-hand side. Here's my fear reading at the start. Like I was a 5, or, oh, I actually went up to a 6. Like the situation actually just increased my fear a little bit. And before even doing it, what did you think was going to happen? Like what was the worst possible scenario? This is usually what drives the anxiety, why they have it. This is where the core fear comes out. And it might be, like, so the one with not the drive-through, but like going to talk to someone at Walmart to ask, like, hey, what aisle is the soap in? His fear would be like, I'm gonna say something stupid and they might like get mad, or they just will be annoyed. And I would have him write down, okay, so what does annoyed look like? And he would say like, they would roll their eyes at me and then like just walk away, or they would give me a look. So those were his fears. Like that's the worst possible thing that could happen. Laughing at me. We would do the exposure and then he would record, okay, what's your fear rating or your SUDS now? And he might say, actually it was, or sorry, during the thing. And he might say, it was actually like, I don't know, a 3, or it was a 4, and then it went down to a 3. Yeah, it was a 3, now it's a 2, or whatever. And then we would record what the end rating was. And then did it actually happen? Those things you were worried about, the things that you expected to happen, did it come true? So, and we would use what he wrote, like, did they roll their eyes at you? Well, no. Did they answer your question? Yeah, actually, they said it was an aisle 10. Oh, okay. Did they like laugh at you and like roll their eyes and make a face at you? No. Huh. Okay. So I guess that's just important and like information to kind of just tuck away in our head. And then over time, like that starting fear rating would go down to like, oh yeah, this is nothing. This is like a 3. Oh, this is a 2 now. So we would just keep doing it until the fear rating goes down. And yeah, this was like a worksheet that I made for us in that context. You can find a lot of different versions, but this is one that I made with him that I thought was helpful. Okay, I'm looking at the time. Let's see. Okay, yeah. Let's stop here and we'll pick up on Friday, just finishing the rest of, we'll go through the qualifiers pretty quickly. It's like the diagnostic criteria for the rest of anxiety disorders. And yeah, that's perfect because then we'll spend most of Friday talking about OCD. Okay. Any questions, thoughts about what we talked about? Nope. All right. If no thoughts or questions, I'll see you all Friday.